Thank you very much, Dr. Nima, and to my colleagues. As you can see, we began with the advanced location of both Seoul and Hong Kong along the Silver Curve. Then we come to India, which of course is a subcontinent in itself with tremendous variations across states. Next slide, please. So this is just a map to give you a visual impression of the demographic variation and the percentage of older population. We, of course, located our study in Kerala, in the city of Thiruvananthapuram, because Kerala is demographically advanced and it has a very sizable population of older persons. And you can also see the the young old, the middle old, and the old. So you get a fairly good idea of the distribution among the older population as well. Next, please. This is just to give you an idea because we heard about financing and the very important role public financing has played, especially in the East Asian context. Seoul and Japan, as well as Hong Kong, the public financing has been very strong. They have a near universal health insurance, although it focuses largely on hospital care. But the Indian situation, and especially in the state of Kerala, it's quite dramatic that the role of the central, state, local bodies is relatively smaller, as a result of which the out-of-pocket expenditure is very high. And we have data for older populations which clearly show us that the percentage of older persons, the cost of care, out-of-pocket expenditure goes up. And this is really largely due to the very targeted public health financing that we have for insurance, and absolutely a very minimal expenditure that we have for social care. Next, please. So what we really, I'm going to present now is the findings from our case study, which is that as you saw in the Seoul case as well as the Hong Kong case, we have multiple actors and agencies in the financing and provisioning of health services. There is a public-private mix in financing of health services. You saw the large out-of-pocket expenditure and a very small percentage of private insurance coverage. And what we are finding is a fragmentation of public financing. This kind of speaks to what Alex spoke about governance. And I think this is very important if you look at the sources of financing. So you have financing from the center, state, and local bodies. And in the private financing, out-of-pocket payments dominate and private insurance is rather small. Now, public provisioning is the primary health centers, secondary and tertiary hospitals. In private provisioning, you have a large private practitioners, you have nursing homes and tertiary hospitals. But these operate in silos. So there is very little speak between private provisioning and public provisioning. The only place where there is some level of mix is through the targeted public health insurance program, which actually empanels private hospitals to provide services with public financing. Next, please. And in social care, we find a very difficult situation. We don't see the kind of maturity that you see in some of these East Asian countries that have been ahead in the silver curve and are innovating to make social care more functional for older persons. Here we really are finding a weak public provisioning and financing, and families continue to be the dominant provider of care for older persons. You have a few community-based initiatives with NGOs, and in Thiruvananthapuram, we have only around 16 public old age institutions, largely targeted toward the destitute poor. But what is also interestingly happening in the Indian context is the growth of for-profit enterprises, catering largely to middle and upper middle classes, and a non-profit institutions, as I said earlier, largely catering to destitutes and poor. They are marginally supported with public subsidies, but these subsidies are very inadequate. And we have several interviews which point to the problems of weak public subsidies. And what we really find is the demand for care services is actually not adequately supported by supply. Next, please. So when we move to the integration with within health services and with social care, there are a couple of things I think we need to highlight. One, that given the multiple actors in financing, there is weak integration in the public sector. What we found significantly interesting was that the integration between allopathic and other systems of medicine is practically non existent. Although, with chronic conditions and multiple morbidities, older persons tend to opt for other systems of medicines as a management strategy. We found that this was a major gap, which we found through the case study. And then also the integration within the public sector across preventive, curative, and rehabilitative care is also weak. And it was interesting to hear Hong Su's presentation, where there have been efforts at the local levels to bring in the preventive, curative, and rehabilitative to somehow speak to each other. This we find is actually operating in silos. And the targeted public insurance scheme basically privileged curative hospital based care. So I think we have a lot to learn from East Asia, that if we create a model which is excessively focused on hospitalization at the cost of preventive and rehabilitative integration, then the health system may actually become inflationary in the long run. And the other issue is the private sector is focused on curative services, poorly regulated, and the integration between public and private sector is very weak. They operate in silos, and there is really no formal linkages between health services and social care in this case. Next, please. Next. Okay. Um, can we go back to the earlier slide? I'm really sorry. Yeah. So as I said, the challenges that come up for the integration, one is the changing family structure, especially in Kerala, due to outmigration of children. And therefore you have a lot of and there is also feminization of aging. So there are studies which are showing us how a lot of older persons are women and they are actually living alone. So this is a major challenge as far as the demographics are concerned, and that there is a lack of social protection for older persons, that there is no universal pension scheme, which is why it also corroborates with the high out of pocket expenditure and also a denial of medical care because you're unable to pay for it. And then the split between, and this again, Alex's presentation showed for Hong Kong, the split between ministries of health and social welfare results in fragmentation and really raises a number of challenges for governance. There is a shortage of skilled professionals, especially from Kerala, due to outmigration, and the shortage of skilled workforce in both the health and social care sectors. So you have a lack of regulation and accountability and a lack of public private partnership guidelines. So some of the challenges that they are facing in East Asia, we see it glaring in the case of the Indian context in general and the Kerala context in specific. And there are financial barriers in access to health services and social care. Inequalities across gender and class become very, very evident. And also, there are a whole lot of questions for the quality of care that is being given. Next, please. So there are some innovations, especially in the Kerala situation, where they have had programs at the state initiated programs to improve access to medicines for chronic conditions for older persons. And this is done through the primary healthcare system. And they're also trying to find ways to strengthen primary level care for older persons. These are innovations. They have to be scaled up. There is co-location of allopathic and ayurvedic services in certain primary health centers, but this doesn't mean that there is portability of records between the two or a dialogue between the two. There are some experiments at daycare centers for older persons in the community. And I think a very well-known initiative, which is actually a WHO collaborating center, is the Pallium in Kerala. And they have really done very interesting work of engaging with the community and local government for palliative care. And of course, palliative care covering a range of conditions, which also covers older persons. Next, please. So, as far as we are concerned, what does policy need to address in this context? And Kerala can become a model for the rest of India as well. It is the first state to have a policy for older persons. Having said all that, I think there are many challenges. One is fragmentation in design and implementation, both within the health services and across health and social care. And how do you build interactions between the public and private sectors for health and social care with equity as a concern at the core? And third is financing and capacity building in a decentralized manners. As we saw, there are some innovations. So, what are the learnings from that, and how do we upscale it? And the regulation to include accreditation and certification for caregivers and institutions. And I think this becomes particularly important, not just for the private sector, but also for the public sector, and to also have SOPs, standard operating procedures, which could then be used to improve quality. And what we really think is important is an ecosystem of regulation for a specialized range of services. So we have to see from home-based, community-based to specialized care. And again, if you do it in silos, then you don't get from a perspective of the user, this ecosystem perspective becomes very important. And no regulation is possible just by government diktats. I think self-regulation of professionals in both public and private sector becomes very important. We also feel that there is a great euphoria about e-health and digital technology in the Indian context, but I think there are many issues around it, including the hardware issues, the availability of smartphones, but also that there are regulations that are required and there are ethical concerns. And there have been a number of debates about the ethical concerns around infrastructure costs and as regard to e-health. We also feel that capacities for monitoring and evaluation of needs and services required for older persons becomes very, very important. And therefore, I think the learnings from East Asia for the importance of needs assessment is very, very critical for the Indian context. Otherwise, how do you plan for services if you don't know what the depth, the scope, and the extent of needs are for an aging population? Thank you very much.